Good morning. Good morning, Aishwarya. Good morning, everybody.
Hi, good morning, Dr. Hudson.
So everything is fine?
Yes, yes. Shall I just run my presentation through with you?
Good morning. Oh yeah, I just turned the YouTube on as well. And now we
Okay.
are live on YouTube. We had our Independence Day yesterday. That was great.
Oh, belated Happy Independence Day.
Yeah, thanks. How is things going in India? Is COVID settling down? It's getting better?
Yeah, some parts it is, but some parts it's not. So it changes every day.
Yeah, pretty much like here, but they say that sometimes spots of infections and more people and more statistics doesn't actually mean it is a second wave or a third wave.
Yeah.
So I think this thing's gonna stay for a while, but then it's gonna be okay. We are gonna be okay with that. So I changed the hospital name. It was only Aditya Hospital, and I added Jyot as well. Iyer told me, and I changed it to be just right. Did you get? Did you guys get the link?
Yes, we did, and I've shared it with some of my colleagues who will be joining in shortly.
Yeah.
Are we having any of the fellows from there, sir?
Yes, I invited our fellows as well, and I will just send them again the invitation. It's a little bit earlier here for us, not very much so. It's already 7 a.m., which is okay.
Right. Is that a little early?
But people have to gotta get used
Mhm.
to the new schedule. So let me admit, there is a policy in Zoom that we cannot have people come in without going to the room, the separate room before. But hi, Natarajan.
Good morning to you and happy Independence Day.
Good morning. Thank you very much. We are happy about that.
So you got a
And
new glasses.
yeah. Sometimes I wake up, I prefer to put them on instead of the contact lenses. They're cool. Huh?
Okay.
I like this contact.
Now you look like a professor. I look like a student.
Yeah.
Good afternoon, Aishwarya.
Good afternoon, sir.
So, so today you are making mainly me and after 15 minutes, who's talking?
Sir, I'll start. I'll just do the short presentation for 15 minutes. And then Jaydeep sir will be doing the teaching work. And then you and Hudson sir can moderate, sir.
Right. Yes. So I told Dr. Jaydeep is joining. So Sunday morning we did a good webinar on COVID and eyes. So Dr. Jaydeep presented on everything about COVID and CRAO, CRVO, and all the thrombo-inflammatory problems happening in the eye. And we had an endocrinologist who spoke about the COVID itself. Good
And
afternoon, Jaydeep.
you have many
Hello, sir.
cases of COVID and this affection, the
Yes,
CRPO.
we have one patient. We have sent for a publication. They're waiting for the publication. And we have one more patient, probably is coming with a report. He has got CRAO and CRVO.
Yeah, you've got one of each.
Yeah.
And
No.
it's proved.
The same
The
patient.
same eye,
He's
sir.
a one eye. Same eye.
Yeah, okay, the same eye. And this is proved it's from COVID?
No, sir.
COVID,
We
yes.
are waiting.
So the previous patient, COVID patient, had the antibody positive. And also, I think HRT CT was showing changes. Plus, I think the PCR was positive.
Yeah, the PCR, yeah. That's great.
So the patient's father, mother had, and the patient had. Young lady.
Mm-hmm.
So Jaydeep,
Hopefully,
I think
they're going to be
Yes,
isolated.
sir. Can you hear me? Can you hear me, sir?
Yeah, I can hear you, Jaydeep.
Yeah.
Yeah, very
Yes,
good.
sir.
Aishwarya,
Sir?
Dr. Pooja is known to you?
Yes, sir. She is my senior from college. She's also a Vitreous Fellow working at Amrita,
Okay.
sir.
Okay. Hello, Pooja. Welcome.
Good afternoon, sir. Yeah, thank you so much.
Welcome. And meet Professor Hudson.
Oh, hi, sir.
Professor Hudson is from
Good afternoon, sir.
Liana from Brazil.
Good afternoon.
And then he also works in Brasilia. And Dr. Jaydeep is our senior consultant.
Good
Hello.
afternoon, sir.
Hello, Dr. Pooja. Good afternoon.
Yeah, thank you,
Pooja
sir.
has worked at,
Aishwarya is our
in-
best postgraduate, so it's happy that she's presenting on such a big platform.
Welcome. So, Jaydeep and Aishwarya, we can start. And whoever Asta and Amit can join whenever they are ready.
Yes, sir.
yeah, we're just
You
waiting
can
for
start,
Dr.
sir.
Hudson PGs also to join in, sir.
Dr. Hudson, we are waiting for your fellows.
Yeah, that's me. Just a moment, please. I also
I have a-
separated some. I
I
also
have an
separated
Indo-Brazil
some.
flag. I
vitreous-
search it. Where is it?
I separated some vitreous pathology pictures as well
Okay.
from a book from pathology that I studied when I was living in Toronto, Canada. It's a nice book, and
This is, Dr. Amrita Arvind, Dr. Vrinda.
So both of them are my colleagues from college, sir.
Welcome. Good evening.
good evening.
Good evening, Dr. Pooja. So when have you joined Pooja for fellowship?
I have joined in March, sir. This March.
Okay.
Yeah.
Okay. So yes. And then Dr. Vrinda, what's she doing?
Hi, sir. I'm doing my final year PG, sir.
Finally. So what's your thesis?
So it was based on retinopathy of prematurity.
And Amrita?
So we have more people from Aditya Jyot. I just corrected the name. It was only Aditya, and then I added
Yeah,
the Jyot
yeah.
on the top. And
Yes. So Aditya means sun god. And Jyot
Yeah.
means lamp, removing darkness around. And like
Oh.
dark teacher removing the ignorance. Ignorance is
Uh-huh.
equivalent to darkness. So that's the symbol.
that's a symbol, yeah. And we have our Muta Aravind, I think first time today, and
Yeah.
Sindra Ramanan.
They are from Aishwarya's old alma mater in South, in Kerala. You heard of Kerala? It's called the
No.
God's own country. No, Kerala is in South India. It's facing the Arabian Sea, south of Maharashtra, Mumbai. And the west
How
coast.
long ago?
1.5 hours flight. And then from the
okay.
airport, another 2 hours.
Uh-huh.
So Kerala, every village is connected. Almost every village is one after another. So even in the highway, you have village. which is connected, unlike the other parts of India. And a lot of backwater, so we have a lot of the what do you call the boat houses are there, resorts. So, Hudson, anybody joining from your side?
Yeah,
So will
sent
your
the
PPT be long?
invitation. I think we should start in 1 minute. I think it's okay.
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 Okay. And I got your mail for sending the video. I'll do that for the retina next week, 13th, 12th December.
Oh, yeah. Did you send the video yesterday?
No, I'm not sent. I got your mail. I'll do that.
Ah, okay. Then you just tell me what your subject is going to be. We have already the video from Lawrence. Lawrence from the first time he is participating.
Yeah.
Yeah,
So Lawrence is my very
from-
old friend. He is my very old friend. From LA.
He's such a good person, humble, and
Yes.
you know, I like him a lot. Yeah, we've met in the meeting in San Francisco, American Society of Retinal Specialists, some
Right.
years ago. And you know, now we cannot
So in
you know, meetings
2004,
for a while, but soon there will be. I hope next year, Brazilian Society, our meeting is going to be okay. And so if
In
you
2000
want to start, that's okay with me.
yeah.
And I think people
Aishwarya,
are going to...
anybody
Yeah,
wants to
sure.
take
I
a
think
point?
you can
We'll all mute and you start, right?
Right.
start.
Yes, we are
Okay.
muting.
So can I
Over to you.
share my screen?
Yes, go ahead.
Sir, you have to make me the host so that I can share my screen.
Hudson, you have to
Yeah.
make Aishwarya co-host.
Oh, yeah. Let me do that. We co-host... That's fine. You already co-host. And Natarajan co-host as well.
Right.
Sir, I'm not.
No, you have made everybody not the Aishwarya.
Yeah? It's okay
No,
now?
still Jaydeep you have made. I think you have to make Aishwarya. She's going to be there.
Yeah, can you share now? It's okay?
No, still you have to make Aishwarya the co-host. Aishwarya.
Oh, sure. Okay. Yeah, all right. Because the names are a little similar, so sometimes
Yes. Yeah, I know. I think.
it's okay now.
Okay. Over to you, Aishwarya.
Yeah. Can you see my screen, sir?
Yeah, very good.
Yeah.
Yeah.
Okay. 1 6 7. Yeah. Okay. Hi. Good afternoon, everyone. My topic today is anatomy of the vitreous. So I'm just going to be presenting something very basic so that we all get a proper understanding of it, so that in the coming classes, when we discuss the surgery and the surgical steps, we have a better understanding and visualization of the same. So just a brief outline of what this class is going to be like. Just going to give you some basic introduction to the vitreous, what is the gross anatomy, then the development and the embryological aspects. And here and there, I'll be adding a few clinical pearls as to why, this understanding this anatomy is important. So just a little bit of a small fact. Vitreous is basically derived from the Latin word vitrium, which means glass or glassy. So it's a clear, transparent gel form that fills the vitreous cavity of the eye, and it occupies about 80% of the volume of the eye. And interestingly, 98% of the vitreous is made of water, and only 2% is made of other substances like collagen, salts. So we'll come to the biochemical composition a little later. So here's a picture. So we can see it's like shiny and glassy, and it looks transparent. That's why it's called vitreous. So coming to the embryology. So the vitreous is comprised, it starts first off as something known as primary vitreous or primitive vitreous. So it's formed at about the 4th to 5th weeks of gestation. So the lens and the optic cup, the lens cup and the optic cup, the space between the two, it starts getting filled up with mesenchymal cells and the fibrils and vascular channels of a hyaloid system. So there's something called the hyaloid artery, which is the blood supply to the primitive eye. And it's branched out. It's got a lot of branches, which is called arborization of the hyaloid system. So together, all of this forms the primary vitreous. So initially, the vitreous is not transparent. It's got a rich blood supply, and it looks like this here. Let me just show you the pointer. Right, the second picture. Then we come to what is PHPV. So the clinical pearl with respect to this particular part of embryology is that in some children, there will be a persistence of the primary vitreous and it will fail to regress and become transparent and avascular. It will always be opaque. And there will be a remnant of this, which is called as persistent hyperplastic primary vitreous. This is one of the differential diagnoses for leukocoria in small children. And we must always keep this in mind without, directly jumping to conclusion that it is something else. Generally, when we see leukocoria in kids, we tend to jump to the conclusion of a retinoblastoma. So you should keep this in mind definitely and rule this out before we can do that. Right. So coming to secondary vitreous or definitive vitreous, around 7th to 8th week of gestation, it starts to condense. The hyaloid artery starts to regress. The arborization, happens, and it becomes, the collagen fibers get laid down in a more compact and a fibrillar way. And the primitive hyalucytes that originate from the vascular primary vitreous, that's the mesenchyme, they are present. And they're produced by the collagen fibrils start being secreted by these hyalucytes, and they result in the expansion of the secondary vitreous volume. Small amount of hyaluronic acid is also starting to be present, and now slowly this becomes avascular and transparent, and due to the way the collagen is laid down and due to the fact that it becomes transparent and the water content decreases. So as this happens and the protein content decreases, as this begins to happen, slowly from the opaque vitreous, it starts to become more and more transparent and it starts to occupy more volume of the eye. So in the 5th month, there is something called hyaloid atrophy which occurs. The hyaloid artery starts to become atrophied, and it forms something called the Cloquet's canal or the canal of Cloquet. This arises from the optic disc. There is a small space over the optic disc where the vitreous is loosely attached. It's like a small bursa sort of a space. That is called the space of Martigiani, and it ends in the retrolentive space of Erglet, also called the Berger space. This Cloquet's canal is basically an S-shaped course, and it has a downward dip in its central portion, as you can see in the picture here. So this is the Berger space behind the lens, and the space of Martigiani behind the optic disc. So the S-shaped dip, the connection between the two is the Cloquet's canal, which is a remnant of the atrophied hyaloid artery. Okay, so coming to the clinical pearl related to this. So sometimes there will be an anterior remnant of this hyaloid artery, which is called the Mittendorf dot. It is seen as a small opacity in the posterior capsule of the lens, which looks like a posterior capsular cataract. So this is a remnant of the hyaloid artery attachment. And in the other side, that is in the posterior segment, when there is a remnant, that is in front of the optic disc, it's called a Bergmeister's papilla. Okay, coming to the tertiary vitreous, between the 3rd and the 4th month of gestation, the collagen fibrils are now very well laid down. They now form the secondary vitreous, tertiary vitreous, and it gets condensed and it's now completely transparent and it's formed the final vitreous. And the condensation of this, from the lens equator till the end, that is till the optic disc. This is called the tertiary vitreous. And now the zonular apparatus of the lens ultimately develops anterior to these collagen fibrils. Now, coming to the gross anatomy. So the vitreous body is mainly divided into two topographic areas, the central or vitreous and the peripheral and the cortical vitreous. So the cortical vitreous is further defined as a anterior hyaloid vitreous and the posterior hyaloid. It's commonly known as a hyaloid membrane, but it's not really a true membrane. So as you can see in the picture here, the light blue area in the middle is the core vitreous or the central vitreous, and the dark blue rim that you can see that is adjacent to the retina is the peripheral vitreous or the cortical vitreous. The intermediate area in front near the aura, that's basically the basal vitreous or the vitreous base. I'll be coming to that in a bit. Okay, so the anterior hyaloid, it begins 1.5 millimeter anterior to the ora serrata, and the anterior hyaloid membrane, the anterior bounding surface, it has a retrolental indentation called the patellar fossa. It's the anterior depression of the vitreous behind the lens, as you can see here. So the vitreous is coming like this. It's not exactly a sphere, right? It bends a little bit in front of the lens so that it can accommodate the shape of the lens. So the Hyaluido capsular ligament or the Wiegert's ligament, that's an annular region of the attachment between the vitreous and the posterior lens capsule. The width is about 1.2 millimeters and the diameter about 8 to 9. And it's firmly attached in young children. The Wiegert's ligament is very strong. And also in children in people with intraocular inflammation like posterior uveitis. So as you can see here, this is the Wiegert's ligament, which is the area where the vitreous is attached to the posterior capsule of the lens. Coming to the vitreous tracts. Now, these are fine sheet-like condensations of the vitreous tissue. They basically are like canals or like passages. They are foldings of the vitreous. After they attach to something, they are related to something, and then they fold within itself and form these tracts or vitreous condensations. It gives rise to an onion skin type of arrangement. So if you've seen an onion peel or an onion skin, it's formed of many layers, right? So this, when you cut an onion, the cross section, what you see, those round layers like the rings. So this also looks similar to that. I will show you the picture as you can see here. So in the middle, there is something called the retrolental zone, which makes sense because it's just behind the lens. So it's called the retrolental zone. Then on the right in the periphery, just in front of the retina is the pre-retinal zone, which forms the pre-retinal tract. So between the retrolental tract and the pre-retinal tract, you have the middle zone, which is the intermediate zone. In this intermediate zone, there are two tracts, the coronary tract and the median tract. So coming to the posterior hyaloid or the cortex, it's about 100 to 110 micrometer thick, and it consists of densely packed type 2 collagen fibrils and other extracellular matrix components arranged tangentially to the retina. This is very important because if the tangential arrangement to the retina is what we are interested in because of the vitreomacular interface disorders. So I'll just come to that. It's thin over the macula due to rarefaction of collagen fibrils, borders of the ILM of the retina. So the ILM of the retina and this posterior hyaloid membrane, they form the vitreomacular interface or the vitreoretinal interface. So as you can see here, there's an OCT picture of the normal vitreoretinal interface. The exact nature of the adhesion, how it stays stuck is not very clear, but what we do know is that it's because of the action of the extracellular matrix molecules found at this interface made of type 4 collagen, the fibronectin, laminin, and the type 1 collagen. So the relationship between these forms that bond in the vitreomacular or the vitreoretinal interface. So the interface disorders, as we have all heard, the vitreomacular adhesion, vitreomacular traction, epiretinal membrane, and macular hole, they result from some disorder in the vitreoretinal interface. If one of the factors that keeps it adhered or keeps it well formed in a good balance with each other doesn't work properly, then we will have all these vitreoretinal interface disorders. Now coming to the attachments of the vitreous. The vitreous base is the strongest attachment of the vitreous. It's most firmly adherent and strongest at the ora serrata, where the vitreous base is there. Then we have the posterior lens capsule, the hyaloid capsular ligament of Wiegert, and then it's attached firmly around the margins of the optic nerve head, at the macula, and around the blood vessels. The attachment of the vitreous around the blood vessels is variable and the most weak. So the vitreous base, it's a three-dimensional zone centered on the ora serrata. It's the strongest attachment, and the functional base extends several millimeters into the vitreous body in this region. So this picture shows the attachment of the vitreous base. It's basically a zone that connects the anterior vitreous cortex to the posterior vitreous cortex. The core vitreous is a cell-free mixture of hyaluronic acid and collagens. It's a gel or a liquid, and that depends on the age, the refraction, and the pathological conditions of the eye. In young children, it's the strongest and most solid and most gel form. And in the older patients, it's more liquid because of vitreous liquefaction, and it's enclosed by the vitreous cortex. Now, coming to the functions of the vitreous body, the main function of the vitreous body is to fill up the eye and support the eye. It forms up about 80% of the volume of the eye, like I said before. So it forms the shape, it keeps the shape of the eye, the spherical shape. And it also forms a diffusion barrier and a metabolic buffer. And it also provides an unhindered path of light to the retina. So as the light enters the eye through the cornea, lens, so there has to be a transparent medium for it to go through so that it reaches the retina without any problem. So that is one of the main functions. Then coming to the biochemical composition, it's made of three major components: water, collagen, and hyaluronic acid. So the macromolecule constituents are your collagen, that is type 2 collagen 90%, and 10% of type 9 collagen. And hyaluronic acid, that's a type of a glycosaminoglycan. It's formed of N-acetyl glucosamine and glucuronic acid. And there are 10% of soluble proteins. Now, it's important that the soluble proteins are low, and they are kept low because that's what keeps the vitreous in this transparent condition and allows the light to reach the retina properly without scattering it. Now, coming to the physiochemical properties of the vitreous, one is your optical properties, then we have plasticity, viscoelasticity, gel stability, and molecular sieve effect. So what are the optical properties of the vitreous? There is something called transparency. So the vitreous, the collagen fibers inside the vitreous body are arranged in a way that it is rendered transparent, and the high water content. Then there is, like I said before, the presence of low amount of soluble proteins accounts for less scattering of light or absence of light scattering. Then the light transmission, 90% of the light gets transmitted between 300 to 1400 nanometers. Plasticity, it's the three-dimensional arrangement of the collagen fibers, which keeps that gel sort of, the configuration of the vitreous, and it retains its shape. That's what it's about. Then viscoelasticity, the negatively charged hyaluronic acid molecules precipitate extreme volume changes with change in physiochemical environment. So basically that is to do with the barrier function of the vitreous. So as the ionized particles from the anterior coming to the posterior, from posterior to the anterior. So it maintains that balance and it maintains the viscoelasticity. Then there is the gel stability. Collagen and hyaluronic acid interact to stabilize the system, termed as the frictional interaction, and molecular sieve effects. It selectively inhibits the movement of water, large molecules, and cells. So that was a brief presentation on what the vitreous is all about. I hope you now have a good idea. Over to Dr. Jaydeep, sir, who will teach us in detail about this. Thank you.
That was great, Aishwarya. Very good review. Congratulations.
And thank you so much.
Thank you, Aishwarya. That was a great presentation.
Thank you.
Well, I suggest that we'll have a discussion. There's nothing that I am going to teach about the vitreous anatomy, but one thing why we should know about vitreous anatomy is when we deal with various diseases of the vitreous, then we need to know this so that we can understand how the pathophysiology of particular diseases is occurring, and then we can plan the treatment. Especially then when it comes to surgical management, we need to know the anatomical landmarks and how the vitreous is formed at various age groups, not only in adults but across from pediatric age group to the geriatric age group. We need to know how the vitreous changes with age and with different pathologies or different conditions. So that is why we need to know about the embryology, the anatomy, and the physiology. So that was a very excellent overview what you have given in 10 minutes time. So what I would like to just add is that when you read about the vitreous anatomy and physiology, what you need to do is correlate it with diseases. So whenever you read a particular disease, or you're trying to read a theory of a disease, or you're going to read something regarding vitreous surgery, just go back and refer to this anatomy and the physiology so that you get a clear understanding about what you are dealing with. So now
Right.
that we know what the vitreous is all about, every time you approach a particular condition or a disease or patient which you see in the OPD or in the OR, then you know exactly what you're dealing with and how you should manage. So certain pearls about surgery, I'm sure Dr. Hudson and Natarajan sir can share with us when it comes to managing different kinds of conditions related to the vitreous.
Yeah, you are right. And we got to be very careful managing the vitreous. But I think the most important in a vitrectomy is the real vitrectomy. Because I'll tell about an example. I operated on a patient who is today, I saw him 2 months ago, 24 years old. He was 4 years old with toxocaritis and attraction, fortunately not on the macula, nasal to the optic nerve. And this boy was operated very early with 4 years old. And today we see nothing but the clear media, no vitreous. The aqueous humor is doing its job, but the patient has got a good vision, 20/50, because he had with 4 years old, he had some amblyopia as well, but everything's so clear. So by doing the removal of the membrane in the due time, we avoided not only vitreous haziness, traction, and these affections that Aishwarya commented on, like pucker, macular pucker, fibrosis, and that we avoided having the lens opacity. So the patient is pretty cool today, and it's very important to go after the vitreous. And the difference in the vitreous composition comparing ages is quite clear. You have to know what you are dealing with. And we know that the vitreous is more attached, especially at the weaker ligament on the lens in the earlier ages. And this tends to soften and with time, and also the posterior hyaloid tends to be more loose, and sometimes you got a PVD. And so you know the attachments at the macular area, at the vessels, at the optic nerve, at the macular area, at the vitreous base, at the ora serrata. You got to be very careful doing vitrectomy. You got to see the vitreous. And in the past, I commented this last week when we talked about the vitrectomy, basic vitrectomy. We used to have these lenses, Lander's lenses, that we rotated the lens to take a very good look at the retinal periphery. But today we have better wide-angle lenses, but also we have to rely on those lenses, especially the macular lenses, in order for you to see the vitreous. You gotta try to see the vitreous. It was so interesting that Aishwarya commented on the Cloquet canal or the Cloquet channel. You can actually observe this channel in the biomicroscopy, and reading books from early ages from Busacca, the Italian guy. Actually, I was reading the French version. It was translated into French. But Busacca studied into his office the patient, and he would stand with the patient there at his slit lamp for about 1 or 2 or 3 hours drawing, and he was cool. And it's possible to see the changes, the Y shape from the beginning of the vitreous and the cloquet sign and cloquet space there, and you follow the vitreous all the way through the retina, and you know whether it's detached or not. So it's very important that you do the whole thing. So when you, as Jaydeep said, when you go to the vitrectomy, things are not easier, but you know what you're doing. And as I showed as well last week, a surgery dealing with what I call triple PO. We're dealing with the vitreous, the posterior hyaloid, the apparatal membrane, and the internal limiting membrane as well. And to remove all these membranes, you cannot do that all together. You gotta differentiate them from the vitreous and its attachments. So this is really important. And thank you for your amazing slides. And I'll have more comments from Natarajan, from our retinal fellow. I'll introduce him to you, Carlos Alberto Pinto from our service. And then I will show you something else, and you are free to comment. Thank you, Aishwarya.
Thank you, sir.
Carlos Alberto, do you want to comment on, did you like the slides? Were amazing.
Thank you so much, sir.
And let me share with you some of my slides over here. I just want to go over some of them because I don't want to be repeating what Aishwarya already said. And can you see the screen?
Yes, sir.
So this is our city, our retinal fellowship service. This is an international omics meeting. And we still have to do things from the past, as I said last week. They work, Today we have more equipment. It's a lot easier to carry on vitrectomies, and the composition of the vitreous, Aishwarya already told us. And it's interesting to know, as she pointed out, that the regions where to go after when doing vitrectomy: vitreous core, vitreous base, and the vitreous cortex. So if you are into the vitreous core in the middle of the retina doing vitrectomy, you could be, slower with the cut rate, slower as well, and the part from the vitreous cutter could be open more time. So there won't be much consideration into getting any tractions. But if you are at the far retinal periphery, you gotta be fast. You gotta be very fast. Otherwise, you could pull on the vitreous and cause a retinal break at the very retinal periphery. So that's what Jaydeep was considering. You gotta be very careful doing these surgeries and without the appropriate settings from the cutter and from your equipment. Fortunately, we have a lot more better equipment from times before, and we have here the vitreous separated from the retina, collapsed to the left. This is a great slide from University of Toronto. And this is, I don't need to explain this again, and the vitreous varies with the composition with the time, and there is, even though we know that the vitreous, we have 99% of water, we have other products inside the vitreous, also proteins as well, and it's possible to measure them. And here, Gaussian blue, with Gaussian blue, it's a preparation from vitreous demonstrating a syneresis cavity. Acid mucopolysaccharide stain positive, so everything in the photo micrograph except for the syneresis cavity is blue. So it's a good way to see the vitreous as well and the syneresis. And by observing the patient, you gotta know where they are. So it's easier to create a cleavage plane from these areas so that you carry on the vitrectomy in an easier way. And we think the vitreous is so important. And in the past, we could not do very many get samples from the vitreous because of ethical problems, and now we know that many studies carrying on studying these proteins. We have diabetic patients and many studies showing vitreous compositions. It's a lot better than in the past, and some injections inside the eye, they affect the vitreous as well, and they might also detach the vitreous, so we got to be very careful. And we don't use that, at least here in Brazil, we are not using G3 to detach the vitreous. So by doing the vitreous detachment as well, we could create the vitreous detachment and loosening its attachments to the macular hole, and we could sometimes close and sometimes avoid a macular hole, for example. And so a couple of more examples here. We have asteroid bodies, saponified fats, soaps, hyaloid asteritis that are calcified. Histologically, they stain positive for calcium, ulcerine red, and be refringent with polarization. But not very many people today do these pathology tests, but they are still good, you know. And even though the view of the fundus is frequently obscured by light reflecting from these bodies, patients seldom experience vision loss from asteroid hyalosis alone. Even though you find dense asteroid hyalosis, the vision is usually good, but I found some cases. I had done vitrectomy for patients with asteroid hyalosis and retinal detachment as well. But no question, you have to clear up the vitreous and do the vitrectomy the right way. And it's usually bilateral, and although frequently asymmetrical, in contrast to synthesis scintillans that has to see with cholesterolysis bulbi, which is usually unilateral unless a patient has experienced bilateral vitreous hemorrhage. There's just a differential diagnosis, and you see here different from the cholesterol deposits from synthesis scintillans. You have here calcium soaps from the asteroid hyalosis. And of course, we have to, as Aishwarya pointed out, the vitreous base has a very strong attachment, and you see here anatomical boundaries. You see down there on the left, you see this hole, small hole over here. You see oral base, and all sorts of things. You have to observe the vitreous and be careful without doing vitrectomy. After doing vitrectomy, if you remove the vitreous without taking care of these defects, you might get a retinal detachment during the vitrectomy. That's why you need to do a very good observation of the vitreous with the indirect best, and also draw, as we explained last week, and many of you already do it, and draw with the appropriate colors. And we are talking about vitreous, so I won't go over all drawings we did last week, but we have opacities in the media, vitreous hemorrhage, vitreous membranes, hyaloid ring, intraocular foreign bodies, and the way to draw is usually on green. You have here the intraocular lens as well, and you have the vitreous opacities, and it's very interesting if you could draw everything, so to get familiar with whatever is going on before carrying on a vitrectomy. I think that was great. Natarajan, do one comment on anything? Jaydeep, how
Yes,
would you do vitrectomies for, like we see here in Brazil? It's very common. I don't know whether it's common in India, but we have so many cases uveitis with toxoplasmosis. toxoplasmosis is very common over here. And so, of course, I wouldn't be keen at doing vitrectomy for toxoplasmosis in patients unless the vitreous is too hazy. Or how much of a haziness of the vitreous you decide to, no, I have to do vitrectomy now because it's too hazy. How much percent in terms of percentage? 20%, 30%, 50%, or you would just better off waiting for time to clear up the vitreous?
Well, yeah. So I think we wait for the active inflammation to go away. When there is an acute toxoplasmosis and a retinochoroiditis, so we'd rather wait giving the treatment and under systemic steroids and immunosuppression. So after the lesion heals and the inflammation is subsided, and there is significant vitreous opacity still there, or if, as in your case, you had some kind of epiretinal membrane or peripapillary traction or something, then we go ahead and do the vitrectomy and clear it. And in case there is any tractional detachment or a vitromacular traction or peripapillary traction pulling the macula, that we deal with that at that time. So in the acute phase, I don't think we go in and do the vitrectomy unless we're thinking of some kind of subretinal abscess or endogenous endophthalmitis kind of picture where we don't know about the diagnosis, whether we are not sure about it, and we take a vitreous biopsy. And
Yeah, this is good discussion because if you have a patient, you are just following up the patient and then he's got a retinal detachment, of course you have to go ahead and do a vitrectomy. That's why I'm asking this is to...
There's a detachment, yeah.
Yeah, and I want to tell you about a case. I'm recalling a case also from a boy, 7 years old. He's got this Bergmeiser papilla, but before being Bergmeiser papilla, he had this PHPV and the vitreous attachments up to the lens. So it was causing some tractions at the papillar area and also some hazy media. So I did a vitrectomy. The patient was 7 years old. And, you know, these patients, Natarajan, they are so successful when you get them early, in the early ages, when they're very young, like 7, 6, 5, 8 years old. Children, they have a very good outcome when you do vitrectomy. And I never, you know, I told you about 2 cases. In the first case, in this case, the lens is so clear so far. And the vision from this last boy, even though he was 8 years old, but he had some traction, some haziness, but he already developed vision. So he's 20, 25, you know, and the lens is clear. This is interesting.
Actually,
so I always try to not touch the lens.
Okay.
Because, you know, the lens survives.
True. I've had such cases as you described. So when those try to spare the lens and they have very good outcomes later on, as you suggested, Dr. Hudson. But some of them, when they are having a very opaque lens, posterior capsule, or there is a kind of a membrane which is formed behind the posterior capsule, a vascularized membrane, especially, then in that scenario, I have done lensectomy and then removed that vascular membrane and then done the vitrectomy and left the child aphakic, but there was no choice because there was absolutely no view. But otherwise, yeah, sparing the lens definitely makes sense. And the anatomy in PHPV of the ciliary body and the lens is very crucial because there are these ciliary processes which are turned anteriorly, which you can see, and you know, you might end up causing a retinal detachment while you're trying to do the surgery, or when you even make sclerotomies, you might end up causing peripheral dialysis.
Yes. And another point that you have to see the other way around too. If you have lens opacity, of course, I have to remove it. Otherwise, the patient in very early ages is going to develop amblyopia as well. And so we have to think about all things. And what is your approach removing the lens? You go anterior or you go posterior from the pars plana and do lensectomy, or you go anterior, and from the anterior part, you just remove you do, if you cannot do arexis, because sometimes it's so elastic, you go that way, and then you just remove the
Anterior,
lens
yeah.
aspirating.
I've been doing mostly the anterior approach in such scenario because it's very difficult to predict what you will encounter posteriorly when you don't have a view, especially in these kids. So I put a AC maintainer, and then through the side ports with a cutter, I make the rexis and then aspirate the lens material out, and then see what is inside, and then decide how to go about it.
Yeah, I do the same. I do an AC maintainer, and after everything is completed, I tend to use the posterior line to take a look, and then I wouldn't probably remove all vitreous, but at least the central core, and sometimes if I'm not able, or I don't think it's necessary to insert the intraocular lens at this time, and then I would just do a posterior capsulotomy, even with the intraocular lens inside, because these children, with time, they develop such a posterior capsule opacity. It's very common.
Absolutely.
And so it's difficult to do YAG laser on them because the capsule is very fibrotic.
Yes, primary capsulotomy, I also perform the posterior capsulotomy primary because they will develop very thick PCOs and it's very impossible to yak them.
So Hudson, okay, whether Carlos or Nicole want to ask something, or Pooja? Do they want any questions or anything they want to add to Aishwarya's presentation and your presentation? Anything you both?
Hi, Nicole. How are you? Nicole is our retinal fellow, and
Hello, Nicole.
and Carlos Alberto is there too, and they are very welcome to discuss. And Nicole, do you want to ask a question?
Pooja?
Hi, doctor.
Hi.
Hi, Nicole. No, I want to see whether Aishwarya and Hudson missed anything in the slides. We want to find some faults, you know.
Yeah.
Pooja?
Yes, sir. Please tell me.
No, Pooja, is Pooja there?
Hello, yes, sir. Yes, sir. I'm there. I'm there, sir.
Anything Aishwarya missed or Hudson missed in the presentation?
Most of the topics they have covered well. So, yeah.
Most means what is not covered.
Yes, sir.
No,
Nicole,
what is not covered?
I want to ask Nicole. Nicole, have you been doing with, not only with me, but with the other guys as well, how you approach the vitreous in terms of visualization? You go doing vitrectomy, core vitrectomy first, and then peripheral vitrectomy. What is your thought on that? Você começa no meio da vitrectomia ou vai direto para a periferia? Nicole, you're there? And Carlos, your thoughts?
She's muted.
Yeah, he's muted? Yeah, let
Yes.
me ask him to mute.
Unmute.
Yeah. No problem. They are learning the system. Zoom is not very easy to carry on. Now, the residents did not show up today because they have these, at the same time, they have these cataract surgeries. And so only the fellows were able to join us today. But today we have 2 fellows from our part, and next time we're going to have more, I promise. Yes. And the thing is, Natarajan, that I find very interesting here is for us to talk and relate, understand? That's more important than having the lecture on the YouTube later and watching and learning. No, we have to discuss. This is the good thing. This is good. We talk about, and as I was discussing with Aishwarya, Jaydeep, and Dr. Kandula as well. And this is good, that we talk. And I'm very happy to have you here. So we also review things, and it's good for our service. It's good for our relationship. What are your thoughts on that, Natarajan?
Amrita, do you have anything, or Vrinda? Aishwarya, you can ask them.
Yes, sir. I actually have a doubt.
Yes, ask.
So why do we need to know the two types of vitreous, that cortical and core vitreous? Does it make a difference in the surgery when we are doing the surgery?
Yes.
Yeah,
I
yes,
usually
it does.
start. Yeah, of course. I usually start doing the vitrectomy at the very middle. We call core vitrectomy. The core vitrectomy is where the vitreous is more loose. The vitreous is not attached to any part. There, in the middle of the vitreous, as I was explaining, you can put the speed from the cutter slower, and that means that the cutter will be open and close, open and close, open and close, and get the vitreous inside, so you get more vitreous in the fill time. This you do in the middle, slower cut. So the vitreous in the middle, the core vitreous, is more loose. That's why we usually start the vitrectomy at the middle of the core vitreous, as opposed to the peripheral and the cortical vitreous, because it is attached, as you mentioned, in certain areas, such as optic nerve, the macular area, the vitreous base. So you gotta be extra careful there. Otherwise, if you go too slow in the vitreous cutting, you get tractions, and then you create a hole, break, and the very retinal periphery. So you got to be very extra careful. And so there, at the retinal periphery, the cut rate is usually very high. So by, the part from the cutter becomes open and closed very fast, like that. So the vitreous doesn't get in and cause tractions. So these are things to observe. And I was mentioning last week, we are doing the vitrectomy, the core vitrectomy, and then we approach the macular area where the epiretinal membrane was. So if was too slow, if I am too slow, I may get the membranes inside and tear, and create a big hole in the retina. So we have to be very at this point, very close to the retina, that I usually put the cut rate very fast. So by cutting very fast, the likelihood of you getting the membranes inside the port and causing traction and tearing the retina is better. So the core vitreous in the middle, but when you approach the retina at the macular area or periphery, you gotta be faster and more careful.
Okay.
Sir, and can I ask you a question, sir, regarding the drawing of a vitreous hemorrhage? Can you hear me?
Yeah, go ahead. Yes.
Yeah. How do we differentiate when we are drawing, especially vitreous hemorrhage, when we are representing on the chart, fresh vitreous hemorrhage and like an old vitreous hemorrhage? How do you depict the hemorrhage on the chart?
Vitreous hemorrhage is always drawn with green. Yes. Whether
If it's
it's
an
old
old
or
vitreous,
you have to label it. You have to write there that it is an organized old vitreous hemorrhage, which looks dehemoglobinized. So you just have to label it. You can't draw it with some other color.
Okay, sir.
Yeah, you're right. For example,
is for only where is the layer, anatomy, and not for the history or the duration. So the duration all comes in the notes. But I think the idea of the color coding which Hudson showed us, so just look at a picture. I think without a word, how any picture speaks 1,000 words. Here, in the retina fellow, anywhere in the world, we should be able to converse without anything. That's why the drawing is very important. And that's why that article I've sent you that, I think Hudson, you got the copy, right? I sent by email. The article of indirect ophthalmoscope and drawing. No? Yeah, Aishwarya, I think you should send by email to Hudson.
Okay, sir.
Yeah, I think you mentioned last week, but I did not get it as of yet.
Okay. Okay, and
Oh,
I think I
yeah.
didn't
Please
send it.
send, please send
Aishwarya,
me.
I sent to Aishwarya.
I'll
Aishwarya,
forward.
it's by Rosenthal. It's a 1965 article by Rosenthal in the Highlights of Ophthalmology, edited by Benjamin Boyd.
I was
And
not
again,
even born yet.
but it is contribution from South America,
Yeah.
Benjamin Boyd.
Yeah,
Yes.
interesting.
So anyway, so I think the color coding is very, very good because it's standardized, and the color is by anything above the retina shows is green, and the below will be brown. Whether it's a foreign body, choroid, anything behind it. So the color coding is really interestingly done well, and universally, I think, accepted. Even though the retinal detachment classification, there's a controversy, but color coding, there's no controversy. So the duration is you have to label, and usually in the diagram you don't look for duration. And the idea of drawing is you are getting involved with the anatomy of the eye of the patient, which is very important when you're operating. And I think the problem is in a young adult, if you're going to operate on a kid, I think the PVD is not there. So many times you think you've done the vitrectomy, and still there will be vitreous, and that's where the experience counts. So what the mind does not know, the eyes do not see. So you have to develop your eye to see the vitreous, where everything is
Yes, and
transparent.
also, Natarajan, some residents and fellow, when they start, they tend to go too deep and go and do core vitrectomy, but we cannot leave the anterior hyaloid as well. Have to remove everything, but sometimes we are afraid we're going to touch the lens. And with the appropriate movements from your hand and moving the eye, you don't touch the lens, but then you have to remove the anterior hyaloid as well. Don't go too peripheral. Some lenses allow you to go too peripheral, but if you go too peripheral and if you cross, and then you might touch the lens. So gotta be careful with those things.
So there
And
is a basic
drawing gives you very good
there is a
information. Drawing.
So there is a basic science requirement for an experienced vitreoretinal surgeon is like how hyaluronidase was once upon a time used, or alpha chymotrypsin, for doing the zonulolysis. Similarly, I think we should find a pharmacological agent which is not available today, but if somebody can work on it, where you can work on, you should know the vitreoretinal anatomy for that and the physiology. We can dissolve the vitreous retina adhesion. I think the most of the vitreoretinal surgery will become easy for anybody. Anyhow, I hope it will happen one day because now every surgeon is skilled or getting skilled to manage that abnormal vitreoretinal adhesion, which is the problem. And that's what is the problem in retinal detachment, PHPV, ROP, everything. And everything is only abnormal vitreoretinal relationship.
Yeah, and Natarajan, because we are talking about the vitreous, how often you use triamcinolone to stain the vitreous?
So I think whenever I have a doubt, particularly young people, I use triamcinolone because you can't. Many times you think you've done a great job, particularly macular hole, and that may, or a younger patient with a macular hole, or a retinal detachment in a young following trauma. Particularly when I did this pellet ocular trauma, most of them were 15 to 20. I don't know what happened because of the pellet injury. PVD was not happening at all. So I think many times you feel, and there at least the vitreous hemorrhage was there. Usually when vitreous hemorrhage is there for some time, PVD happens. But in pellet ocular trauma, it's not happening. And the same thing is true for Tersen syndrome. When you have a bilateral vitreous hemorrhage following Tersen syndrome, I don't know, PVD is not there at all. I don't know why. I think it's because the hemorrhage is coming via the pia mater into the optic nerve sheath, into the vitreous. That's a very interesting, Dr. Aishwarya. All of you should read that, how Tersen's syndrome has a subarachnoid hemorrhage with the vitreous hemorrhage.
Yes.
The continuity of the
Good thing,
brain.
and
So,
you
but
mentioned
in those patients, there is no PVD.
no
And a
PVD.
vitrectomy is very difficult. I think I've seen many times I thought a vitrectomy is very fast. I think the fastest vitrectomy I've done is 6 minutes. But I remember with Tersen's, it takes 1 hour or just for a simple vitrectomy. There's no membrane dissection, just to remove the vitreous hemorrhage.
Yeah, I
Because it
have a
doesn't come.
case of Terson syndrome that I operated on both eyes. And interesting, the first case, I could do vitrectomy, and the vitreous was quite attached. But the vitrectomy, I published this on iTube, like I think 1.5 years ago, and I could remove. Guess what? You won't believe it, but it's there. It's recorded. I could remove the internal limiting membrane that was loose with the cutter. I could remove the internal limiting membrane. That was great. With suction, it's very difficult. But
Yes, sir.
after doing
I've had such a
vitrectomy,
case, Dr. Hudson. I had exactly a similar case with bilateral torsion, vitreous hemorrhage. When we went inside, I saw there is a sub-ILM hemorrhage. The whole ILM is raised and there is blood under the ILM over the posterior pole. And it was so loose that no staining required and you could remove it. Of course, I removed partly with the forceps and partly with the cutter. But you could
yeah,
feel it
yeah,
just with suction from the cutter.
yeah. This is interesting. We
got to
should
know
gather
that.
It was
these
exactly
cases.
identical in the other eye.
So you
Yeah.
got to
Hudson,
know that there is a subialum hemorrhage only after doing the vitrectomy, sir?
Yes,
Okay,
because there
okay.
was vitreous hemorrhage, you couldn't visualize the posterior pole.
Right, right. Okay.
But
Yeah, we
when I
should
went
gather
for the
these
next eye, I
cases
was prepared for it.
Okay.
yeah, we could publish these cases. You know, these are quite common. I'm seeing like you did it, and interesting for statistics as well.
Anybody has read about vitreous anatomy by John Wurst from Holland? You heard of it? So that's again a homework, I think. You should see the anatomy of vitreous by John Wurst. He has used that Indian ink and stained the vitreous and give us a different anatomy. But I think worthwhile knowing
Okay,
what's
sir.
his views, even though it's not popular. Wurst anatomy, John Wurst.
Okay, sir. I'll check it out.
All right.
So,
Sir, I have
You could
doubt.
send me this too.
yeah. Yes, Aishwarya, ask.
So Hudson, sir, you had shown one picture wherein the vitreous was stained with Alcian blue, right?
The posterior detachment. What did you ask
No,
actually?
you had stained the vitreous with Alcian blue dye.
No,
That was a slide, I guess.
Yeah, a slide, a histopathological section.
Histopathological section.
Yeah. So, sir, that is what is the use of that? Like, why would we do that? It's something that is done in vitro, right?
yes, but this was just for explaining just some slides from University of Toronto. But so we are just explaining the hyaloid asteritis, for example, how we recognize them, and just some nice photos on that.
Okay,
And
not so it's not applicable
it's interesting.
clinically, right?
It's a pathology. We gotta do more. You know that we are doing more pathology today because you know the OCT came about, and after OCT, we studied pathology more, and now we see the OCT all layers, and we are not studying that much pathology. But I think we should.
Yes, sir.
I'll
Right.
introduce you, Daniel.
Oh,
Daniel just
Daniel.
woke up. Daniel just woke up, and I'll give him a retina book, so he's gonna start to learn. Say hello, Daniel.
Hello.
So, Aishwarya, your friends are not asking any question.
I think they're shy, sir.
No, you ask them to come on the camera and meet us so that they remove their shyness. That's the idea of the meeting.
Brinda?
I'm happy they all joined. Hello.
Hi, sir. Hello.
You have any questions or suggestions?
So she covered almost all thing, every anatomy. And I think how the vitrectomy differs in endophthalmitis cases, huh? Like those in
Differs-
PDR and all.
No, what is your,
Endophthalmitis.
no, I understand.
Sorry.
But what is the Jaydeep? You understood their question?
Yeah. Can you repeat with that?
So how the
You are asking about
vitrectomy differ
vitrectomy?
in endophthalmitis, sir?
Vitrectomy and endophthalmitis. Well, see,
Yes,
in
sir.
endophthalmitis, how it differs is certain steps, initial steps when we start the vitrectomy, right from the making the sclerotomies, we have to modify the approach a bit because we need to understand what is the goal. Our goal is to first take a sample and then vitreous sample and then debulk the vitreous as much as possible to reduce the infection load. We are not trying here to do a complete vitrectomy.
Yes.
So the vitrectomy proceeds in such a way that first you don't start the infusion line. You take a cutter, go inside, and first take the sample with a syringe. Make sure that the globe doesn't collapse while you're doing it. And once you are sure that your infusion cannula is inside, then you put the infusion cannula on. Otherwise, you can start with the AC maintainer if you have no view, and then clear the media sufficiently to visualize the infusion cannula and only then put it on. So that is one important step where you might go wrong and end up with some complications if the cannula is suprachoroidal. Then once you go inside, you do core vitrectomy only. When you can visualize the remaining part of the vitreous, you go step by step. Don't try to go in the periphery in cases of endophthalmitis. Just stay in the center. So as you visualize, then you decide whether you want to go further in the periphery or not. So one good thing here is you should do as less as possible in endophthalmitis cases as is required. You can always come back and do a repeat vitrectomy to clear the remaining portions of the peripheral vitreous, but at no cost you should have a retinal break. And the retina in these cases is inflamed and is very friable. So trying to go close to the retina, you're going to end up with breaks. The other thing which you should avoid is inducing a PVD.
Yes, sir.
So don't try to induce a PVD unless you feel that it's already there and the retina is not involved. So you have to decide case by case, but generally avoid inducing a PVD.
And you
So
also
with-
should keep the toxins in mind, which will produce retinal necrosis. So even if you have not produced traction, as Dr. Jaydeep said, you have to keep in mind there's a risk of toxins producing retinal necrosis because of the bacteria. You can have retinal detachment post vitrectomy. So that's why nowadays we use silicone oil in some eyes. Again, it will vary from patient to patient.
Right.
And
So basic
you gotta
idea
be
is
very
to
careful.
avoid basic idea is to avoid any iatrogenic complication in endophthalmitis, because what happens is you're used to doing the vitrectomy for RDs, macular holes, and your idea is to clear the vitreous completely, have a clean retina when you close the case. That's what we normally do. So by reflex, when we do the endophthalmitis case in the beginning, we also try to, do the same. You try to you try to go right up to the periphery, clean the vitreous, make sure that the whole vitreous retina is clear. But over enthusiastically, if you try to do something, you will end up doing some kind of complications, which is very unforgiving when it comes to endophthalmitis. So that is something which you should avoid.
Thank you, sir.
Pooja, want to ask something? Good. So next week we are having anatomy of the retina, right? Aishwarya?
Yes, sir.
Next week.
Yes, sir. Anatomy of retina next week.
Okay. So Hudson?
Okay.
That was great. I learned a lot from you. A very good review, and we discussed things and cases, and that was nice. I'm very happy to be here again, and it's a pleasure to see more people. Some people we already know, and some we are
So I
knowing.
suggested in the notes, whatever Aishwarya prepares, you can bring out a manual.
Yes, sir.
Yeah,
Fellows,
we can
like the Wills Eye Hospital manual.
can compile all the topics and the
And
presentations.
also, I think Wilmer also brought it, I think. It's all done by the residents. So I think it's a, and with
Sure.
the teachers support. But I think we can bring that so that it will be useful for the future fellows.
Sure, sir. Definitely.
All right. Thank you for participating, everybody. Thank you, Nicole. Thank you,
Thank you.
Carlos Alberto.
Happy Independence Day for Daniel.
Yeah. Happy Independence Day.
It's a Brazilian Independence Day.
Yeah, thank you very much.
Yeah.
Happy.
Yes. Thank you, Jaydeep.
Thank you.
Thank you. Thank you, sir.
Thank you.
Thank you,
Have a great
Aishwarya.
day.
Thank you, everyone.
Thank
Thank
you
you,
so
Dr.
much,
Hassan.
sir. Thank you.
Thank you. My pleasure.
Yes.
Bye-bye.
Bye.
Bye-bye.
Bye.